Seeing lots of familiar names, so that's really exciting. This is my first public event since the summer, so since June. So I'm happy to be back with such a really, really strong group of humans today. So I'm sure we're going to talk about a lot of really important and very interesting stuff. And I think we'll give it a minute or so. Marigold team, what do you want to do? We still got people kind of making their way in. Aw, look at all those Manitoba folks suffering in the cold.
Gimli, Manitoba.
Hell yeah.
Yep.
Okay.
I think we're probably ready to start now, Ashley. It's Bridget.
Okay, perfect. Thank you so much, Bridget.
And welcome.
To the entire Marigold team. That's a great place to start, actually. So welcome, everybody. My name is Ashley Brown. And I just want to thank, first of all, the Marigold team for helping us with all the logistics and promotion and organization, and for providing us with some guidance, both technical and otherwise, on today's webinar. And also to thank our wonderful guests, Dr. Amy Bender, Dr. Shelley Turner, Karen DeBroni, and Lynn Beach. We are very excited to speak with all of them. They have unique lived and professional experiences, and it's going to make for a very one-of-a-kind discussion today. I want to give you a little bit of background on Ekosi and what we're going to be talking about today. So Ekosi Health is a Canadian-based and Manitoba-based, an Indigenous-owned leading provider of quality healthcare. By maximizing research findings and strictly adhering to their in-house developed practices and procedures, they are really paving the way to deliver harm reduction oriented, innovative, and very personalized method of care. So they're really, I would say, Ekosi Health is unique in that they're helping each patient be their best personal self, which is something in medicine we looked and long to see more of. So this event is going to discuss current research and the ways that they're advancing cannabinoid-based medicine, how to integrate cannabis as a harm reduction tool, and the choice of when to choose cannabis or cannabinoid-based therapies over traditional drug prescriptions. And one of my personal favorite topics, health equity, and lots more. So one thing I want to start off by saying, and anybody that's from SheCan or has heard me speak before will know that I repeat this, and I repeat this because it bears repeating. There are no silly, stupid questions. I can't tell you the thousands of times someone has started asking a question in the SheCan community or otherwise, and they've said, I know this is a stupid question, but in cannabis especially, I want to emphasize, we'd love to have you engage in the chat. You can type your question in the chat as we go. There's going to be a lot of information, and I know for a fact that every one of these panelists wants to make sure that you understand and walk away with the information that you came for. So
I know they're recording it.
With that in mind, I think we're going to get started, and I would like to start with a land acknowledgement. So we would like to begin by acknowledging the Indigenous people of all the lands that we are speaking from today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the land, which each of us call home. We do this to reaffirm our commitment and our responsibility to improving relationships between all people, and also improving our own understanding of each other. So it's a pleasure to have you all here. We're going to kick off with some introductions, and I'm going to make sure that all the panelists tell you all the most wonderful and important things about themselves. So I'm going to keep mine very short and to the point. I am the founder of SheCan Cannabis, which is the country's largest and most engaged, thank you very much to everyone who is, community of medical cannabis patients. It's also a platform for advocacy and a really important voice in a lot of the research that's being done. So even when that page is inactive, I always want to reassure people there's lots going on that their voices have contributed to. I'm a patient myself. I live with intractable epilepsy and Parkinson's disease, and cannabinoid-based medicine has been a large part of my personal journey. So I really take a lot of pride in bringing the SheCan community's voice to stakeholders and regulators and the industry itself. And I can tell you from experience that having known both Karen and Dr. Turner for several years, they are very aligned in a lot of the work and are very aware of a lot of the need of the patient community in Canada. So I'm going to start with Dr. Shelley Turner. I'd love for you, Shelley, to introduce yourself and tell us a little bit about what makes you really incredible. And I will not be dissuaded from that.
Okay, well, well, what about my plants here? Like, really?
Field
nice.
of dreams.
That's right. So it's really nice to see everybody. I do recognize some names out there, and I send my best to the SheCan community. Talk about a stellar community of women that support other women on this crazy cannabis journey. So I am the founder and chief medical officer at Ekosi Health. This essentially has been started with a focus on my practice based in addiction medicine and the need to provide more information and more research, more guidance to my colleagues. So with that, we've got a number of projects on the go, but we did do the inaugural Cannabis 101 with Red River College back in the day. Gosh, I think it's like 2018, 2019. And then, of course, with all the lovely work that we're doing with Dr. Amy Bender and her incredible team, but really focused on data acquisition. We have over 20,000 interactions over the years and really collecting information and the patient's voice. And I'll stop there.
Well, I'm going to let you off the hook because I would have maybe done it differently, and it would have sounded something like, Dr. Turner is a superhero and has seen tens of thousands of patients and impacted their lives in magnificent ways. But we'll go with yours. I'll let you off the hook this time. Dr. Amy Bender, I would love for everyone to hear from you and tell us a little bit about yourself.
Well, thank you for inviting me to be a panelist here. I'm very excited to be here. My name is Dr. Amy Bender. I'm the Director of Clinical Sleep Science at Cerebra, which is a sleep technology company focused on better ways to diagnose and treat sleep disorders, and also looking at different interventions to improve sleep in everyone, which brings me to helping out with this particular study and seeing how cannabinoid therapy can improve sleep quality. I've been in the sleep field for about 15 years now, first starting off as a sleep technologist and then getting my master's and PhD in experimental psychology. I'm also an adjunct assistant professor at University of Calgary as well in kinesiology. So I do a lot of work with sleep in athletes as well. And that's about it for me.
Wonderful. I have so many really nerdy questions, but I am saving them because I have this entire time otherwise. So I'd love for Karen DeBroni to step up to the mic and introduce herself, give a little bit of background.
Thanks very much, Ashley, and thank you to everyone for being here today and spending some time with us on this important topic. From a background perspective, myself, I've worked in many different industries and sizes of organizations and for-profit, not-for-profit over the course of several years now. I have been involved in the medical cannabis industry since 2013-14, where someone I worked with in a previous life was starting out on an entrepreneurial venture and asked if I'd like to come on and be involved. So worked inside of the organization to pull that organization through to sales licensure, and then had the good fortune of meeting Shelley, and we connected. And there was an opportunity to be directly connected to the patient community with which we would serve. So that was in about 2018-19, and we've spent this time in the last number of years trying to build something that is much larger than ourselves. And from a personal perspective, that's something that really drives me. It's working inside of communities and trying to make a contribution to the betterment of the community in which I live, and really globally we're focused. So very pleased to be here and looking forward to spending time with you all.
Thank you so much, Karen. I will add a postscript to that and tell you all that Karen DeBroni was the first woman in cannabis I ever met, and she was actually the first person in cannabis to hear about SheCan. I remember it fondly because I said, yeah, we have this little group and it's just about 100 people now. And I think Karen knew that I was in deeper than I realized. So here we are. Thank you so much, Karen. And I will argue the most important voice, maybe I'm biased, but the patient voice, the lovely Lynn Beach. Lynn, if you'd like to introduce yourself.
Thank you so much, Ashley. I rarely been referred to as the lovely Lynn Beach. Partly then I go back to my work. And for 30 years, I was a police officer in Ontario. So my introduction to cannabis was seizing it, charging people, or dumping it at the side of the road if I didn't want to do all the paperwork. I retired in 2006, and I still was not knowledgeable on anything to do with cannabis, except from, say, a criminal code or a legal point of view. Certainly nothing in the way of personal use. And I think if you go back into the olden days when I first started policing, we weren't talking then about it being a remedy or a help or an assistance to anyone. It was a recreational drug. And that's all I grew up with, if you will, in my 30 years of policing. And then subsequently after that, that was indoctrination. So when the infamous Dr. Shelley began to talk to me about this, and to give you a little bit of background and anybody here, she had been my physician. So she was well aware of my, I won't say illnesses, my ailments and my issues. And so she started on her journey asking me to participate also. And I think she found me a tad reluctant due to my background. And it took her several years of persistence to get me involved. And what I have found then is a world of betterment of my life, if you will, watching others, friends of mine, improve and enjoy life more because of what we have out now. I've been involved in a couple of studies. I saw some familiar faces on the board, which was nice to see. And I think I'm interested in learning more. Has it helped me? Immensely. I can't say enough about what it's done, but I do realize it's an individual thing, and it's an individual process and learning experience that you go through. And I will stop now before you get the hook out for me, Ashley. And I thank you for everything you do, by the way, because I do enjoy SheCan.
Oh, thank you very much, Lynn. Even before you had said those lovely, probably untrue things about me, I was going to say I'd let you talk forever because, again, I reiterate, the patient voice is often the most powerful, and yours certainly is. So thank you for that lovely introduction. And it kind of launches us into kind of the first phase of the Q&A. So we're going to talk to some of our really bright and shiny brains about different aspects of cannabinoid medicine and of community empowerment and patient-centered care. So I'm going to start off by asking Dr. Shelley Turner a little bit about something a lot of us encounter, which is the discussion around lack of research. So there's always been this kind of touch point around cannabinoid medicine that there's not enough research to justify integrating it into healthcare practice. How is it that we can improve on this, and how can we advocate for more research?
Mm-hmm. For me, I'm a McMaster grad, and again, this background is kind of like being out in the weeds. Gord Guyatt was, the father of evidence-based medicine, and I sat at it in his lectures, and he said, if you're way out there, he said, you better be collecting data. And so that's how I kind of started my adventure, and asking the patients to participate in collecting that information and being able to track patients over time, so that you are actually showing that you're not doing harm, collecting as much information about deprescribing, sleep. And again, sleep is a huge issue. I always say if you fix the sleep, everything else follows. So then when you look at a body of evidence of cannabis, I mean, there's a ton of research, anecdotal, in the Petri dish, qualitative data. We do have a lot based on the endocannabinoid system, which we're learning so much more about every day. But the challenges in terms of being able to do randomized controlled trials, which cannabis is really challenging to do. What do we do? And then from a regulatory perspective, and I think Dr. Bender can speak to some of the challenges we've had regarding that. So in the realm of research, the randomized control trial is the gold standard. Observational studies are like, okay, but we need more. And what I say is, what more do you need? Yes, we need the bench science. We need all of that. But you guys got to catch up to us. And so that's why the data, that's why the patient voice is so important, because we can turn that voice into a number that's measurable over time, and find access to other research modalities, the restrictions regarding Health Canada. And I think maybe Karen can chime in terms of regulatory challenges, just with ensuring that the license holder has the ability to participate in research. So community is where it starts. So having conversations like this, conversations with your primary care providers about medical cannabis, talking with people that may be considering using cannabis, and providing education through lovely communities like She Can. But it shouldn't have to come from there, right? It's important that it comes from there, but we should be meeting patients in the middle or helping guide their journey. So those are some of the challenges. And I would argue it's regulatory in nature, as well as stigma within the medical community.
Thank you. Thank you, Shelley. Karen or Dr. Bender, do you want to speak to some of those regulatory hurdles that you've encountered, especially with the study regarding cannabinoids in sleep? I think most of the general public is not aware of a lot of kind of what goes on behind the scenes as, smart folks move through this process.
I can take that, Amy, for just a second. With the research in cannabis, license holders, if you're doing a randomized control trial, need to have something called investigator brochures produced on their product. And very few, just by the way the regulations were established, and very few license holders have that for each of their products. So it's like a product monograph, but even more fulsome. So it does tend to have you working from an observational study perspective in this environment when you're doing research. But internationally and in Canada, there are great strides being made to allow us to move the research forward. And there are many individuals and participants from a patient perspective that are very interested in doing so. So the yardsticks are being moved, which is very good.
Yeah, progress is a process, and I'm glad that I think it speaks to, without going behind the regulatory curtain, because we'll all die of boredom here, it speaks to the tenacity of all of you, that you are where you are, and I know how much heavy lifting comes with this. So I think that it's an important topic. I think another topic that we've all heard, we said the word too many times, but it in some ways has been a watershed moment in terms of healthcare, and the way that we look at healthcare is that the pandemic itself unmasked a lot of things. When we talk about well-being, when we talk about symptom management, we talk about overall quality of life. We saw an increase in anxiety, in pain, in substance use, and sleep disorders. A lot of people who are not sleeping so well and continue to be challenged by that. So, and those are a lot of people who potentially weren't dealing with illness or chronic, symptoms before, who are now, facing an alteration to the quality of life. How, can medical cannabis be integrated into kind of a more normal practice and mainstream practice as a harm reduction tool? So not just as a therapeutic intervention, but using it as a tool for harm reduction. And Dr. Turner, I know you have a lot of experience when it comes to cannabis for harm reduction. So I'd really love to hear from you, because there are a lot of folks out there that don't realize that this is another tool. Cannabis is another tool.
The majority of folks that come to see me are in and around pain, mood, and sleep. Oh my goodness. And so, different flavors of patients where, they've tried everything, nothing's worked for them. And so initiating a cannabinoid therapy, primarily sleep becomes the issue, as well as just being able to deprescribe. So the challenges for patients, we see it all the time, particularly with, and I'll give you an example, patient with opiate use disorder.
TV's just up to the hotel's constraint.
Was using like a gajillion milligrams of Dilaudid. And one of the things that when we talked about in the intake, they were talking about that they would use cannabis once in a while to help them when they were having withdrawal, so that they wouldn't use something like fentanyl. It would kind of tide them over. And what we started doing, and that's kind of how I got into providing access, was watching these patients know what they're getting, understand the milligrams, adding CBD to the mix, because a lot of folks were having, trauma, so lots of anxiety. So that ability to do that work is great, but challenging, because again, it's not covered. Opiates are covered under provincial systems, but cannabis is not. I've had patients have to go back onto opiates because they couldn't afford cannabis. So in the context of what I see everything. Every issue that a family physician would see with their patients, and in and around those domains. If you're able to manage those domains, you're able to reduce medicines, most medicines, particularly over the counter. So when you apply this to practice, when you look at the World Health Organization's pain scale, we start off with, over the counter medications, which again are not benign. People think that they can take, lots of Tylenol, lots of Advil. It's not without harm. So you're going through these levels of weak opiate, and then, you get into the synthetics and cannabis. If we flip that around and try using, CBD dominant products for our cannabis naive folks, those living with arthritis, one-to-one formulations using for sleep, and again in 1 milligram increments. And with the medical piece, particularly with I would say the graying of the green, the majority of my population are folks in their over 65, and they want to sleep, they want to come off their benzodiazepines, and they want something to manage their arthritis. So how do we do that? We collect as much information and do it in a very stepwise approach. So the ability to help people reduce the amount of medication, improve their quality of life indicators is quite high, but it's not for everybody. So that's the other piece, and that's what I'm very interested in too. So the non-responders and the people that can drink a gallon of high THC oil and not even flinch. So it's about the research and collecting that information. So we're essentially building the ship as we cross the ocean with data.
Yeah, thank you. Thank you, Shelley. I mean, I think you speak to a really important point regarding, the idea of deprescribing other medications. And also that's really an important point to make because there's so many drug interactions. So patients being comfortable, disclosing that they are consuming cannabis alongside other medications to their primary healthcare provider, or working with somebody like yourself who has an extensive background in cannabinoid medicine and can, then with an understanding of what else they're using, do so. So I actually do have a question from the audience. It's a really good question because I'm not so sure I could answer it in a sentence or less. What's the definition of harm reduction?
That is a great question. So it's harm reduction is essentially doing the best you can in a situation for someone. So for instance, if a patient is coming to you and they're using a benzodiazepine, and I'll give you a case in point. Benzodiazepines can be quite dangerous, and particularly in our elder population because of how we metabolize it, and you can build up metabolites and you can get delirium. So the colleges are really actually putting a lot of pressure on physicians to reduce the amount of benzodiazepines that patients are on. So you have patients that have been on it for 30 or 40 years, and then they're either being stopped or deprescribed. So there's a lot of risk with just abruptly stopping benzos, right? So what is the alternative? Well, there's a lot of other medicines that have other side effects, but we find that with a combination of THC and CBD, the ability to prescribe something that can help that patient have more autonomy in what they get. So with benzodiazepines, very restrictive prescribing, the patient is having to come in, they're having to jump through a number of hoops and really being gated. And, and there's a whole continuum of that. But then there's folks that, with cannabis, they have that freedom. So from that perspective, if you consider benzodiazepines harmful in that population of people, for sure, I think you can reduce that. When you think of polypharmacy in our elder population, so patient has diabetes, probably guaranteed 3 medications there, different profiles. I'm getting a lot of questions regarding, and sorry, I'm just kind of going off that harm reduction bend there, but just from a harm reduction perspective, absolutely coming in to see somebody like me that can look at those drug-drug interactions. So for instance, if you have high blood pressure, there's a number of family of drugs, 5 or 6 families of drugs that you could take for that blood pressure. But if you start stacking your blood pressure pills, most often people are on 2 or 3, that starts to, Ashley, what path are we going down? The liver is?
A racetrack. Someone wise.
A racetrack. So you have challenges there. And so the blood pressure medication may not work, or it might drop that person's blood pressure. So there's potential for interaction. So from that perspective, we need to be careful. And I was just touching back on that, Ashley. So stop talking.
No, that's
I don't
great.
think I answered that question very well. But.
No, I think you answered it really perfectly, which is you're doing the best you can for the patient in front of you. That's harm reduction. So that to me is actually the best definition of harm reduction there could be. You want to minimize the harms and increase quality of life. And there's a lot of different ways to do that.
Safety wise, so if you're going to look at managing pain, opiates have a high risk. And, there's an opiate risk tool that we use for patients. And depending on your background, you could be at a high risk to develop an opiate use disorder just by me prescribing it to you. So do I think you're going to get a cannabis use disorder? You could, but the chances are much lower and the consequences much less, depending. But it's definitely not death when we talk about opiate use disorders. So.
Right.
Yeah.
Reducing harm, reducing impact. So, something we've talked a lot about, and Dr. Bender, I would love for you to speak to this. We've talked a lot about sleep and sleep being such a marker of quality of life. We have, you work with Cerebra and it's such a big part of things to be able to kind of transform, the way we talk about sleep, the diagnosis of sleep, the therapeutic elements of sleep. Can you talk a little bit about give us an overview of what the state of research about cannabinoids and sleep is, and where we're kind of at this point in history?
Sure. There's a lot of preliminary evidence out there showing the benefits of cannabinoids for different sleep complaints. So for example, there's preliminary evidence showing beneficial impact on obstructive sleep apnea, for example, where you stop breathing during the middle of the night. There's also preliminary evidence showing the benefit on REM behavior disorder, where you act out your dreams during the night, as well as insomnia. And so in our particular study, we're focused more on general sleep disturbances to see if cannabinoid therapy can help improve sleep quality for general sleep disturbances. And we kind of talked previously about how initially we wanted to do a randomized control trial looking at different combinations of the therapy. But in the end, we really ended up wanting to get the research done, provide evidence for the literature, and it would have just taken a long time for us to kind of get those regulatory approvals. So with this current research, we're focused on people with sleep complaints and looking at different time points throughout their treatment. So looking at their sleep objectively before they start treatment, looking at their subjective complaints, and then what does that look like 3 weeks after being on treatment and 6 weeks after being on treatment. And so it's really a unique opportunity for us to add to the literature out there, which is showing, there's not a lot of research out there specifically using objective and subjective measures of sleep. So we're really excited to collaborate on this study and really try and see if cannabinoid therapy will benefit patients. And we know that anecdotally, but we wanted to kind of put this into a formal research project.
It's really exciting. So I can say I did not know about the emerging research on sleep apnea or REM behavior disorder, which is something that's actually very common in people with Parkinson's. So the Parkinson's community will be very interested and watch that closely. But I think that there's a larger conversation here, and the value of this observational study with Ekosi is that these are the lived experiences of people who are currently tackling sleep disturbances. So, I actually have a little bit of a follow-up question, so we'll pretend I'm in the audience and I ask my question instead of just thinking out loud. When we talk about observational studies, are people using products that are given to them, or are they choosing their own products and reporting on that? Is that something?
Yeah, good question. So observational studies you're kind of not manipulating what's going on. There can be more focused research questions, but you're not randomizing a patient to a certain condition. It's more, what is going on? How are they reporting their symptoms? How are their symptoms changing? How is their sleep changing? And you're kind of observing different things as they go along, but you're not really controlling that they're in a certain condition. So for our study, we're looking at a 1-to-1 ratio of cannabinoid treatment with THC and CBD. And so that part is kind of fixed, but within that, we're looking at these different changes among all different types of patients and people that come in that are using that particular ratio and just observing what's going on.
That's very helpful. Thank you. I think it's one of those things we hear those words and we kind of think we know what they mean, but it's really nice to be able to say, okay, this is, it's a common question. A lot of SheCan members and the population at large indicate wanting to participate in different clinical trials and studies, but they often don't know, what's what. So there is a question from the audience, and it's, Dr. Bender, do your ratios differ depending on the sleep complaint, like dreams related to SD?
That's a very good question. And I'm going to pass that off to Dr. Turner because I know I'm focused specifically on sleep disturbances and complaints. I'm not actually the one treating the patient. I'm more of the researcher. So I'm going to pass that off to.
Yeah, she was nodding and nodding. So I think she's got it queued on the inside.
Yeah, I think that is such a great question, Irene. So it's challenging. So just for this particular study, we are using that 1-to-1 ratio. But when we think about PTSD and particularly around night terrors and sleep disturbance, I think Dr. Bender was talking about that ability to be, completely asleep, not moving. So I think that's great. But some of the challenges, and this is where the variation in all you lovely stars in the sky, all your individual endocannabinoid systems, there's some of you that are so special that you have such a THC sensitivity. And so generally we would see that in kind of the first few weeks of using that medicine. People can't tolerate more than 1 milligram or 2 milligrams of THC. So then we start to, mess with the ratios. So adding CBD to that. So that's where that personalized bit comes in, so that you can navigate that, so that patients don't give up, because quite often they'll go to a rec store or their grandchild bought them something, said, try this, and then they've had a bad experience. So dosing is always very much individual. Thank you for the question.
Okay, thank you very much. Amy, I want to ask you about something that I think, it's something you should all be very proud of, is that this observational study, it was very much a collaboration. So the Bioscience Association of Manitoba has an advancing healthcare initiative. They were involved. It's funded by Prairies Canada. Can you talk about just why that's important? Like, why does that kind of collaboration matter in healthcare in general, and in cannabis medicine as well?
Yeah, I think it's a very unique collaboration based on my years of experience doing research. A lot of the research that's being done is in the laboratory. So, for example, I used to work on sleep deprivation studies where in the laboratory, where we would bring people in and we would sleep deprive them for up to 62 hours, for example. But in that laboratory, the light levels were controlled, the temperature was controlled, the participants weren't able to do exercise to try and keep them awake. It was a very, very controlled environment. And this collaboration, funded through AHI and Prairies Can, is a unique opportunity because we're blending the research with an actual clinic that we're working with Ekosi. So it's very, very unique. It's real patients coming in for this research. We're doing the research in the home, and it's in a realistic environment. And that is pretty rare, I would say. A lot of the research, again, is being done in the laboratory. It's being done through university labs. And so it's an amazing opportunity to collaborate with Ekosi, who has their own clinic. They're treating patients, and they're willing to do research with Cerebra and our researchers and collaborators as well. So it's very, very important, and we're very grateful for that funding.
And no one has to stay awake for 62 hours. I hope.
That is true. That is correct.
Not even resident doctors. So, well, thank you so much, Dr. Bender. Karen, I would like to talk to you, Ms. Brony, about, something that it's gaining more traction, and we're just kind of at the tip of the iceberg, which is kind of, people talk about community care and community health care. And I think when we're talking about, coordinating that care and delivering, safe, high quality care, right? Not a one and done, not somebody who doesn't know you, but, collaboration between organizations like we just talked about in terms of this study, the observational study, and Cerebra and Ekosi's involvement, but also the overseeing bodies that are supporting this. What are some opportunities that could help advance cannabinoid-based medicine? Because, obviously this is a very unique experience, and I know Dr. Bender's really excited about kind of the way that this has been presented, and it's novel and it's innovative. What else can people look for? What else should people be talking about when we talk about cannabinoid-based medicine and collaboration?
I think the opportunities are limitless. We're limited by our own imaginations around what we can do to advance cannabinoid-based medicine. There are so many different relations that we have across government, across funders, across other community organizations, other disciplines, other stakeholders that we can bring to the table to work together all towards a common goal. So we see this a little bit in terms of the involvement we have with the My Health team here in downtown Point Douglas in Winnipeg, Manitoba, Canada, where we have many different people coming from different perspectives, coming together around certain initiatives to move together towards a common goal. So in the cannabinoid-based medicine space in particular, it's about perhaps bringing together those that have licenses under acts, wherever it is in Canada or internationally, to allow for the advancement through novel. We have to do it novelly and innovatively to make things really sing in the time period, and at the same time work the long-term game from a traditional biopharmaceutical development perspective. So while we're doing observation studies, lay the groundwork to do more of the RCT study style product development, and then always involve the patients from an active perspective in the research that you're doing, and then make sure that the evidence that's collected is there's real world evidence that you are collecting to help advance the projects, whatever they may be.
Yeah, it's definitely a marathon and not a sprint. And I think when we talk about, you touch on Ekosi, and, for those of you who don't have the extreme pleasure of living in Winnipeg, it's cold here today. I'm sorry. It's just, I think there's a wind chill. We talk about community, and that can look different for different people. And we do know that there is inequity with populations in terms of what they have access to and what communities, receive in terms of how that impacts health outcomes. So, maybe we can touch on something you've already kind of cracked the door open on, which is, when you engage a community, how does that help build, a systemic approach to health equity? We've acknowledged there's an issue. We've acknowledged there's a disparity between how one patient or one, group or population is treated when it comes to accessing healthcare, when it comes to what their options are. How do we go about engaging community and building, a real 360 approach to equity?
Mm-hmm. I think that the engagement will stem from where you start, and where you start is with the group or the community that you're trying to engage. So it's not for us to say what we think they want, that particular community. It's for them to say to us what they want and what they need. So your process of researching and your process of understanding how to build something that's going to be systemic and sustainable has to start from the community itself. And so we're seeing quite a lot and a rise, I would say, in community-based research, where persons with lived experience are involved in the research design itself, and the research design is quite often innovative and new in the way that it's gone about. There's a lot of qualitative research involved in community-based research. And then if we look at particular communities, and we service Manitoba, Saskatchewan, Northwestern Ontario, which have higher than the average population of persons of Indigenous descent in the country. When we look at that particular patient population, it's very important to be carrying out community-based research through free, prior, and informed consent perspective, through an OCAP lens, through recognizing the calls in the Truth and Reconciliation report. So it's very important that it can, every community that you're trying to provide services to, you take the time to understand what it is that they're wanting and needing, and that will help build longer term sustainable return for you and for everyone. Yeah.
Thank you, Karen. That's incredibly important to touch on, because there's a lot of well-meaning folks out there. And there is a wonderful saying that is repeated a lot in the larger global advocacy community, which is nothing about us without us. And it is that idea of having the community, members of the community, or people with lived or living experience at the table. But there's since been a reformation on what that means in terms of participation, and the new banner that they're flying in accessibility and advocacy is nothing without us. So it's actually not just enough for people to be thought of by well-meaning folks or considered, but also to be participating in that way, as you said. So being listened to kind of and integrated into every step of research and community. So I'm really glad you touched on that. I think it seems like something we would take for granted. A lot of folks would take that for granted. Nope, I can tell you, I was on a federal research call a couple weeks ago, and I was the only person with lived and living experience. And I said, oh, and on Monday you don't have anybody. Do you want to maybe have someone there? And they went, oh, that's a good idea. So, sometimes best of intentions, right? But it does come down to, listening and then driving from there. So thank you very much. I'm going to I think I might know the answer to this, and if I don't, Shelley might know. Someone had asked about the acquisition of Charlotte's Web for prescription grow to turn to rosin. I'm assuming that they mean probably seeds or clones to cultivate. So there are several license holders that will sell seeds or clones to medical patients. I believe Spectrum is one of them. They have genetics that you can access if you have a authorization to grow or cultivate medical cannabis. And then there's also the option of accessing Charlotte's Web flower through a licensed producer. And I know that there are a couple, I can think of at least one that has the Charlotte's Web cultivar. So that would be anything to add, Shelley, on that one, I think? Oh, you're good. You're good. No, we got the golden thumbs up. So
Yeah, this actually behind me is a derivative of Charlotte. This is a sweet Charlotte. So it is a high CBD,
oh, Charlotte.
low THC. I know Charlotte. She's been around here. She gets
yeah, the praise she deserves. So
she does.
A lot of people associate that with the story of Charlotte Figge, who is obviously a very brave and important figure in cannabis advocacy, and specifically a lot of the research around cannabidiol. So that's not necessarily the origins of a lot of those cultivars, but I will always and forever take the chance to remember her and her very important family in the U.S. So I don't think I would be talking about this today if it weren't for stories like that. And that's where, we talk about lived experience. And Shelley, that's actually one of the things that we want to kind of start to explore, which is the idea of patient participation. So we've talked about, lived and living experience in regard to research, but, something closer to home for folks is the idea of, how they can participate. So obviously cannabinoid medicine is something that is not necessarily understood or educated upon universally. So not all doctors have the knowledge level you do, but, these patient-centered care models empower patients. What is the patient's job? How can the patient participate? How can a patient really, take the reins when they're trying something new and novel, which for many people cannabis is?
Mm-hmm. I think really it's about knowing oneself. So to give you an example of patients, particularly around pain, so being able to document just from that basic level, patient diaries, that type of thing, but also this disconnect that patients have sometimes in and around pain. So understanding, being open to understanding the mechanism of action, knowing that they have the ability to dose to effect, and that they're not kind of hammered into a box and they have to take this pill and it has to be this often. So participating in that way. And also, I think there's a certain fear about cannabis. So many of my patients will come in and they'll say, I want to try the cannabis, but I don't want any of that THC stuff. And I'm going, okay, I don't want to be high. So there's educating yourself, but also once you're a patient is educating those around you, right? And where to access properly and how to use it in a safe way. But it's really is participating, is being able to collect as much information and document as much as you can.
Yes, document.
Mm-hmm.
Right? It is such a personal experience. Absolutely. I wholeheartedly agree with you on that. Karen talked a little bit about different populations and community-based research in healthcare. And obviously the topic of health equity is something we're not nearly done talking about it. I was reading an article this morning about medical misogyny, and I I went, oh, there's another one we need to touch on. I think we see different intersectionality in terms of access, in terms of health equity, but one thing in particular that I think you can speak to is that individuals living with substance misuse and mental health challenges often face additional barriers. So, how can we impact this by, safely kind of combining new therapies, relatively new therapies like medical cannabis, and also older or more established treatments as well?
Mm-hmm. So, that's kind of what I do, right? Is that whole piece of, and I'm sorry, I don't have it with me right now. I have a Swiss Army knife that has my name on it. And that's kind of what we're trying to develop in that armamentarium of tools that we have to help folks living with a chronic illness, right? Of substance use, which when you flip it around, what is the basis of that? It's trauma. So being trauma informed and having an understanding and seeing where the patient's at. So the challenges around that are access, stigma around that. I mean, we have some great evidence out there that we can, opiate sparing abilities of cannabis. So can you substitute cannabis for opiates, for cocaine, for methamphetamine? How do we do that? And so that's kind of coming back to that question about how do you treat PTSD? What are the ratios? Well, we're going to find out because we need to do those things parallel. So I think there's a lot of interesting things happening right here in Winnipeg in terms of dispensing cannabis, the opportunities to do side-by-side dispensing cannabis and opiate replacement or OAT, opiate agonist therapy. So the challenges are really about accessibility and affordability for patients. And because cannabis is not on does not have a drug identification number, that means that's why it's not in pharmacies. So options are the synthetics like Nabalone. But again, you know, we have patients out there that it may work for them, but we have our sensitive folks out there that, yes, they're using opiates. THC might be too much for them. They may do much better on CBD. So the research that needs to happen on side-by-side dispensation should be happening like safe supply, right? A safer supply. If you had an option to inject, to smoke your drug of choice, or to try cannabis to see if that might help alleviate your symptoms in a protected and safe environment, wouldn't that be something? And I know that this happens off to the side, and it's very promising. It's not the be all end all, but when you combine the Western medicines in terms of things like Suboxone and Sublocade and Methadone, marrying the two, amazing, so that you can create that stability. And then, of course, we're just talking about cannabis. There's other plant-based medicines out there that show great promise in our folks that are living with trauma. So things like our psychedelics. So I'm very excited by that medicine for the particular population of people that I serve. So it's exciting.
Thank you. Yeah, I think that that's a really important piece. And it's maybe part of the, you know, what contributes to health inequity is the fact that, you know, when you flip it on its end, trauma is at the root of so much. And I think between the veteran population and, you know, our Indigenous population and so many folks out there who are suffering from complex PTSD and PTSD, there is a very important conversation around that, you know, parallel dispensing and understanding how it works to validate also the lived experiences of people and through trauma-informed care. So I think that's something that we can never talk enough about. And I think, you know, I said nothing about us without us has now been changed to nothing without us. So without further ado, you know, I'd like to talk to you, Lynn. I'd like to make sure that we have an important and really well-informed patient voice, you know, to kind of fill in the blanks of the journey, because lived experience is something people can relate to. So you talked about your, you know, your journey with cannabis, you know, and how Shelley, you know, kind of was persistent in her suggestion that potentially this was something that may help you. And you know, you talked a little bit about some of your symptoms. You know, can you talk a little bit about what symptoms you're treating with cannabis and what made you go there over, you know, more traditional drug prescriptions?
Well, I think I started my four major symptoms that I see a lot of in articles and research and stuff was the anxiety, migraines, insomnia, and I have osteoarthritis in my knees. So sort of from my point of view, the big four, if you will, but number one was the insomnia. Now, when Dr. Shelley started talking to me about this, and she would send me articles, some of which I understood, some of which I had no idea. I read them, couldn't tell you what it was about, but she knew I had those four items. And the migraines were at the point where, and for those that suffer migraines that are listening here, when you're in tears because your hair hurts, you're in bed sobbing, there's no comfortable position, there's nothing, and you can only take so much over the counter. We talked about over the counter drugs. You can only take so many of those before you start to feel nauseous, and they don't do any good. she prescribed for me a traditional medication for that, which to this day I still have in my arsenal here. And that's, I guess, fear on my part. I'm reluctant to give them up. Not that I use them. The prescriptions I've got, I may use 3 or 4 or 5 a year now. My migraines are weather related. So it's strictly weather pressure. I can't predict. If I see the bad weather coming, it's like, oh, not a good thing. Take a little bit more CBD oil, a little bit more caffeine, I'm good to go. But the severity of them has dropped. I haven't had a weeping in the corner, crying in my bed episode in years. And the only difference in my regimen is, number 1, better sleep, number 2, cannabis oil. The insomnia, she knew I had insomnia. We didn't go there when she was my physician with any traditional medications. I did everything I could on my own. I read all the books. I did everything except drink warm milk at night. And I was up at 1 every morning. And it's, I have found with other patients, other females of my age, and it's a thing where our brains don't turn off at night when we lie down and close our eyes. I could get to sleep, yeah, but I couldn't stay asleep. So to this day, and it's 4 years now, to this day, when I wake up in the morning, there is just a moment of just pure glee, just pure joy. I slept through the night. And for those that don't suffer insomnia, I don't think they understand that that result is just so amazing. My knees, there you go. It helped. I think it saved my knee. I had a total knee replacement in May of this year, and it's turned out wonderful. But I was able to cut out the Aleve portion of pain medication once I started on the cannabis oil. And that was, yeah, well, that was amazing. And then the anxiety, whether that's a female thing, whether I got it from my mother, not sure, but it's reduced dramatically. So that, and you talked about it earlier about sleep being the top one. Once you get sleep, and once you're sleeping better, everything else starts to come together a whole lot better, and you're able to cope better. So I started on this journey, and Shelley has talked about, you're starting low, you go up. I didn't have anybody else to talk to. Shelley was it. At that point in time, I didn't know anybody else that was involved. I finally sort of found SheCan and thought, oh, I'm not the only one. This is great. And I never posted a lot, Ashley, but I did read, and I still read to hear what other people are going through. But a couple of the things I've been involved in, which I wanted to bring up here, was I'm thinking, I'm not going to make an assumption, I'm thinking that the people that are involved in this today, that are listening, are from across this country. I suspect there's people, a lot from Manitoba, but I suspect there's people from all the provinces. We've legalized it across all the provinces, and yet I meet women now that I talk to. Depending on the province they're in, they can't get the product they need. They can't find the doctor they need. They see the studies. All of us join in, and we swap studies back and forth and look at different sources for information. But in our individual provinces, there's holes, for lack of a better word, for some people who've read up, who are knowledgeable, who need it, and there's nobody to go to. Or if they go to their doctor, it's like, I don't know enough. I can't help you with this, or I don't believe in it. So from a patient point of view, I look at it and say, I consider myself hugely fortunate here in the province of Ontario that I've got access to it. I've got a doctor who supports me and who I can call up and talk to anytime. And that is a huge thing from a patient point of view. But then I look at my friends who don't have that access and I'm wondering, how are we going to fill in the holes? So I'm looking at doctors here and I'm looking, you're very knowledgeable in this area, Ashley. And I'm looking, saying, how do we fill in these holes so that we all across the country, so it doesn't matter whether you're in Nova Scotia or Saskatchewan, we're going to get into this together and be able to help each other.
I think that's incredibly astute, Lynn. You know, health equity is something that is also geographic. And, you know, I want to play a little bit of a what if with you because, you know, you count yourself fortunate. I think you're just also very smart. So, you know, you have Shelley as your physician, you're having these conversations. It's a two-way street. You're telling her things. She's emailing you studies. I also nod and pretend I know what some of those terms mean a lot of the times. But, you know, let's say you lived in Nova Scotia and didn't have access to a practitioner like Shelley. What would it look like in the absence of that support? You know, how would your journey have been different with cannabis?
I'm not sure I would have had a whole lot of a journey. I have, partly because I was introduced to this and I got reading and I love to read about this stuff and I love to read the studies and who's going through what. And I've been involved in a couple of small studies and the women I meet are amazing. Women are an amazing creature. We really are. And what I'm finding is people are teaching themselves and we would share stories about, and websites, what's good, because there's a wealth of information out there in the written word, not so much in the calling up of a doctor and saying, okay, here's a symptom I had. If I'd been out in Nova Scotia and I didn't have a doctor to go to, I probably would have had to have my knee operated on at least 2 years ago, for starters. I probably still wouldn't be sleeping, or if I might have had to ask a doctor for an opioid of some kind so that I could sleep. Again, knowing full well that that's the start of everything. And I would feel better if I at least was getting some sleep, but then I'm taking drugs and I don't like taking drugs if I can help it. Even over the counter. So I would have been taking more over the counter drugs. I likely, on a guess on my part, would have had to have started. Or I would have experimented on my own at a hot shop somewhere. And I know if you go in and talk to some of those people, some of them are extremely knowledgeable, and there's a lot from in that area. So if I'd gone in to ask for help to reduce my anxiety, I may have lucked out and gotten the CBD oil that I needed, but I might not. I might have been given a vape pen and told to, whenever I felt a little nervous, have a puff, and not addressed everything properly, I think.
Yeah, I think you just hit on a lot of really, really important things. Like what it comes down to is that, you know, the what if is really impactful in terms of your quality of life, right? Like it would have looked very different. And it's not the absence of access to legal cannabis. That's not what we're talking about. We're talking about the absence of access to informed care and to being able to have that two-way street and what that meant in terms of other, you know, medications you were on and how you dosed and how you were able to ask questions and have that knowledge exchange. And I think you're right. There's a lot of information out there. And I am like you, I love it, right? I love reading about it. I never thought I would ever care about microglial cells in rodents. Not ever, never, not ever, never, ever. But I really do. And here we are. So, you know, I think that's important, but that is a one-way conversation, right?
Yes, that's
So
right.
that's a one-way conversation, but we want to have that engagement because it's a moving and evolving thing that is very unique. So hearing from other people,
Yes.
you know, is at least a jumping off point that feels really human. So I think you made a really
Yeah.
good point. And something else I want to touch on that many people may not be aware of. So I think, you know, Shelley, you and I
I have
we will
something
not-
to.
Yeah, we will not tear our hair out. We will not tear our hair out. You know, when we talk about access, you know, to cannabis, a lot of people, you know, say, well, I can go to the store, you know, I'm going to think of a name. I bet you this is an actual store. So I'm using it for satire, but, you know, so please don't anybody think I'm targeting Bob himself, but you can go to Bob's Bud Hut and, you know, walk in and say, I'm treating arthritis, I can't sleep. Legally in this country, they cannot, under any circumstances, dispense any advice related to a medical condition. So a bud tender, a dispensary employee, you know, a retail shop owner or manager cannot actually dispense. That doesn't mean they don't. That doesn't mean they don't try and help. There's a lot of folks who just really want to help, and I respect and appreciate that, but legally they cannot. And part of the reason that regulation was drafted that way is because it was identifying cannabis as a medicine that does have, you know, drug interactions, that does require medical supervision. And I think, you know, without that constant, you know, engagement with your physician, as much or as little as you need, right? That conversation can be different. So what I hear a lot of these days is people who didn't have access to a healthcare practitioner like Shelley. So maybe they went on their own, or someone sent them, or they got something. And, you know, Daryl has said in the comments, like the dispensary CBD advice was extremely underdosed, right? Because those people probably are really busy trying to make a living and run their store, and they're not reading about microglial cells, and they're not, you know, they're not Dr. Turner, who's living in a field of dreams, working to, you know, better healthcare access for all of us. So I think it's very important to, you know, to touch on that, because the outcome for somebody who says, yeah, I tried CBD, it didn't do anything because they didn't have the advice, versus, you know, being able to go back and say, I'm not sure about this. Could we do something different? And have a credible, you know, health
Ashley,
on the other side is really important.
Ashley, could I think we could make this very simple.
Please.
Would you go to the liquor store for advice on your hemorrhoids? So that's like, seriously.
Me, is this rhetorical? Is this a rhetorical question, Shelley? I just need to know.
But it brings it down to the base level of what people are asking of a recreational store, right? People are looking for help.
Yes.
And so shocking, and again, like you say, with the regulations, but that's how I put it to people when they come in and they go, well, you know, I went to the local store and I asked them there and I said, would you go to the liquor store to ask them about your hemorrhoids, or, you know, the rash that you have on your back, anything topical? Like, you wouldn't, because you know that those people don't have, perhaps maybe they do, and they have a little clinic room in the back of the liquor store. But, you know, for the most part, people, you know, have very good wine knowledge and beer knowledge and spirits knowledge, but not healthcare knowledge. So I think we need to keep that in mind. And that being said, I've been to some stores where you say, Lynn, people have a lot of knowledge and they know that there's benefit, but the challenge is, then what? You know, they don't know your medical history. They don't know the medicines you're on. So for the most part, you're okay, but there's challenges there. Sorry, I'll stop talking now.
No, because you know what? The next time that there's a consultation, if you don't think I'm going to be asking you, did you put that in your submission to Health Canada, you know, about the hemorrhoids? Because it's a great analogy. Like, as much as it's tongue in cheek, it's very true. And you know, I've actually been asked by Health Canada, well, what would stop you from buying, you know, the CBD you use to treat your intractable catastrophic seizures with cannabis you purchased at a retail store? And it is the same kind of, you wouldn't, right? So I think there is an important piece to that, you know, that's a very good and very vivid example. Lynn, I think that's very, you know, it's very important to have this lived experience, and I really appreciate. I think, you know, you bring a really interesting perspective to this based on your lived experience and your career. Like I'm positive that it really you know, it's impactful to people. So, you know, how do you think that's played a role in this journey? Like, you know, your mindset, your ability to talk about it with other people, you know, how does that kind of inform this for you?
Well, as I learned and as I started to realize, as I learned, as Shelley sent me information, as I started to read on my own, as I started this journey of taking this, it was a major change for me. After 30 some years of looking at this as an illegal, evil drug out there, I had to look at it from the perspective, the research that was being done, the articles that I'm reading, the anecdotal information that I'm reading, that I do believe in the anecdotal stuff, because of course now that's what I have, but it took me years to come around to say, this is a good thing. Maybe not for everybody. This is a good thing. And I wish people could go more to their physicians and learn some of the stuff that I did. And then you go out and research it on your own also. I think in this day and age with access to the internet and Google, we can go in and find so much information there. Some that you're maybe a little skeptical of, some of it you just think that's the end all and be all. I love that. But it took me years to get over my preconceived notions and the rigid, I shouldn't say rigid, that's the wrong word. My learning for 30 years was the Criminal Code of Canada and various provincial statutes. So the law was my thing. So to get away from that and say, even though Canada comes out and says, okay, now it's legal. Geez, for years, I threw this stuff out at the side of the road. I lectured people, I charged them. And to go from that to where I can sit here now and talk to people, I go out, I will talk in public about it. And that, from a police officer's point of view, is quite something, because this was something that was a no-no. My children are just, they're still bewildered by all of this, because of course they hid it from me when I was working and stuff. Did I know what was going on? Of course I did, but they certainly would never have talked to them. So there I am now saying, what about this? And how much are you using about that? And that has confused them. Now, these are young adults. But my journey, it took me years to get over this cultural indoctrination that I had and grown up with and worked through, to come out and now say, yes, I'll go out and I will talk to people and say, have you thought about it? Have you read about it? Have you talked to your doctor about it? All I can tell you is my story, and my story I feel is a good one, and it's worked well for me. But as I say, it took me years. It took me years, which is why I think when Dr. Shelley started to talk to me, it was like, ooh, are we going down a dangerous road here, Doc? And she kept up. She says she's a good lady. So it took me a long time. I don't go out and flog it on a street corner, but I will talk to people, and there's good and bad. Here you go.
Oh, I wondered if I'd make it without the dog barking, but of course, it's the mail. It's such a cliche. It's a mailman, so mail carrier. It is actually a male, but he's just doing his job. Both of them, both the dog and the mail carrier. So yes. Thank you, Lynn, because I think, you know, I see this a lot too. It is so funny because, you know, I'm so fortunate, you know, to have been able to hear the stories of so many patients, to be able to share my own story. And what I've learned is, like, that is the most powerful thing that we as humans have, is the ability to tell our story, to share our story, to feel safe doing so. And also, you know, being able to see how that impacts others, and, you know, how they may or may not walk away with something that is of value, or they may or see or hear themselves in that story. So I can imagine, like, it's not a one and done, right? It wasn't something where somebody suggested something, you know, to you and then you moved on. And I think, Karen, I want to kind of take the last question to you, because this is such an important point, is, you know, we hear Lynn talk about things. This is always the most valuable piece for almost everybody involved. All stakeholders want to hear from patients with lived experience. You know, what power and knowledge do patients have that they don't necessarily realize they have?
I think patients really have all the power. It's just like consumers in a retail environment where consumers now have the power. Patients are consumers when it comes to healthcare, and they really control the agenda. And when things get aggregated, the power becomes even much more strong and relatable, and related to those that are in positions of power from a policy development perspective too, to listen to what the patient community is saying. And in order for that power to be realized, I think it's incumbent upon us in the healthcare provisioning space to build relationships with patients, and to engage patients and help provide the right tools for the patients to take an active role in their own health journeys. And so it's a combination of heart, sort of building relationships with the patients. And you hear that with Lynn speaking, you know, it takes time to build relationships. But when you have that, and then you couple that with actual systems and environments and capacities for patients' voices to really be heard, I think there's very, very much power in that, and then the future looks bright for us when collaborators. And thank you, Amy, and thank you to yourself, Ashley, for everyone sort of working together with that end goal in mind. Okay? Mm-hmm.
Thank you so much, Karen. I think that is the perfect way to wrap up this very, you know, kind of action-packed and really empowering session today. I think that there's a lot that I have learned, because there's always more to learn, and I'm sure that, you know, the audience has learned a lot from a lot of different lived experience as well. So I'd love to thank again the Marigold team for their help in coordinating and promoting, and obviously our very, very special guest, you, Karen DeBroni, Dr. Shelley Turner, Dr. Amy Bender, and the lovely and very cannabinoid savvy Lynn Beach. So thank you to everyone, and most of all, thank you to everybody who attended today. Time is something you don't have much of. We never have enough. So the fact that you chose to spend it learning and interacting with us, especially all those comments in the chat, we really appreciate it, because that's how we move ahead, one step at a time, 1 gram at a time. Thanks, everybody. It's a pleasure.
Thanks. Nice to see everybody.
Awesome.